Hi, and welcome. Episode 1 of the COVID Conversations with Scientists, and we're filming this on November 19th, 2020. For our initial episode, we have tackled an important question that many have asked with regard to the COVID-19 disease. Why do people experience different disease outcomes following a COVID virus infection? And importantly, what are the long-term issues that some are experiencing? The ability of people infected with COVID-19 to experience symptoms many months after infection has been termed post-acute COVID, long hauler COVID, and long-term COVID. These patients represent a significant number of people, and we are fortunate that we have two of them here today to tell their stories. I am Don Sodora. I'm a viral immunologist working at University of Washington and Seattle Children's Research Institute. My work to date is focused on infectious disease research, including HIV and more recently COVID-19. The goal for this web series is to do a deep dive into different aspects of COVID-19, including long-term COVID, vaccines, and therapies. We are taking a slightly different tack from other COVID informational web series, as we will present the information in a conversational, or we hope to be a conversational format. Our panelists come from diverse backgrounds, including PhD scientists such as myself, physicians, and in addition, each episode will have a person that is neither a scientist nor a physician to help keep the conversation at a level you might experience around your kitchen table, we hope. Tonight, we have put together an excellent panel to discuss what are the different disease symptoms people exhibit following a SARS-CoV-2 infection, and what are the consequences of long-term COVID. Estimates indicate as many as 10 to 33% of infected people experience long-term COVID symptoms. And this is generally defined as having symptoms after 2 months after they're infected. And there's over 56 million cases worldwide. That translates into millions of people that could experience these long-term complications, which include fatigue, memory loss, GI symptoms, joint issues, as well as heart and lung issues. The panel today includes Doctors Brenna Hill and Angela Rasmussen, Warren Dinges, and Francis Broyles, as well as our non-doctor scientist for this panel is Sarah Sewalelot. Fran and Sarah both had experience with SARS-CoV-2, which is the virus that causes COVID-19, COVID-19 being the disease, and both are currently experiencing long-term COVID symptoms. If you have any questions while listening to this episode, please write them in the comments below, as our next episode will be a Q&A on this topic, and we hope to address as many questions as possible. I'll begin by introducing the panelists one at a time, starting with Dr. Brenna Hill. Brenna is a scientist working at Frederick National Laboratories in Frederick, Maryland. Brenna has spent her career studying immune responses to viral infections and vaccinations, and she will start us off with some information about the different symptoms in the body that are affected by the COVID infection. And welcome, Brenna. And I know you have some slides to share.
Yes, thank you, Don.
And go right ahead.
All right, so what I wanted to make sure to share with everybody is COVID-19 disease outcomes that you might expect depending on the type of infection that you have. So there's several levels of disease severity that happens with COVID-19. There's those people who are asymptomatic, and these are people who test positive for the virus but do not show any symptoms at all. You have those who have a mild or moderate case of COVID-19 in which they do test positive and they have some symptomology, and it may be able to be resolved quickly or only have mild interventions that need to be happening. Then you have those people who are severe. These are the people that test positive and may require hospitalization. And then of course you have critical cases in which the hospitalization is an absolute requirement. Now, the potential symptoms that can be seen with the different levels of severity can range from a fever of greater than 103 degrees Fahrenheit, which you can see with mild and moderate, severe, and critical cases, fatigue, dry cough, but not always, loss of a taste or smell, a sore throat, headache, malaise or body aches, and GI tract issues, and nasal congestion. But When you get more into the severe and the critical cases, then you could actually show up with blue lips, or your facial timbre is a little bit blue. You can feel intense chest pressure, difficulty breathing, altered mental state, like a mental fog or confusion. And then if you get into the just critical case, then you can have a weak pulse, cold hands and feet. You could develop sepsis, and you could enter into organ failure. Now, the internal processes that occur when you're seeing all of these symptoms are the following. One of them is what's known as a cytokine storm. So when your immune system is fighting off an infection, they release molecules known as cytokines that help talk to the other parts of the body and the other parts of the immune system in order to properly do a defense. Sometimes that response can be a little bit too strong, which is known as a cytokine storm, which can lead to a lot of these symptoms that you're seeing in the middle panel. You also see widespread inflammation throughout the body and widespread coagulation, which I'm sure you've probably heard with blood clots that have been detected in several different body organs. And speaking of the body organs, body systems that have been reported to be affected by COVID-19 are not limited to these, but these are the major body systems that have been affected. Of course, you've got the lungs. That's the most identifiable one. Your brain or nervous system, that's where you get the mental fog or the confusion. Your circulatory system, that's where you get the coagulation. Your kidneys, your liver, and your heart. So with that, I'm going to turn this back over to Don so that he can introduce our next speaker.
Great. Thanks. That was an excellent background getting us started. And with that, I will introduce Angela. Angela Rasmussen is a virologist with a position at the Georgetown Center for Global Health Science and Security. Angela appears in the media frequently to discuss COVID-19, SARS-CoV-2, disease progression, vaccines, has an excellent knowledge of the SARS-CoV-2 virus and COVID disease. So hi, Angela. So can you tell us what are your thoughts with regard to the important factors that influence COVID disease progression, which may be the most important for long-term COVID?
That's a really excellent question. And my short answer, Dawn, is that I don't actually know. But my research focuses on the different factors in the host response to infection that lead to one outcome or another, including long disease outcomes, such as long persistent COVID, as well as the acute symptoms or pathogenesis, the process by which a virus causes disease. So there can be a number of factors that contribute to all these different outcomes and the various presentations of this disease that Brenna just summed up so nicely. Those include things like genetics, epigenetics, which is the way that your body regulates which genes are expressed and when, diet, medical history, medical status, immune system status. All of these things can really contribute to the type of disease that you end up having. We do know a few things about the way that this virus interacts with your body. For some people, this virus appears to be a pretty profound suppressor of what are called interferon responses. And interferon responses are cytokines that are really crucial for your body mounting an antiviral defense. They're essentially like a fire alarm and a sprinkler system all in one. They alert the body that an infection is there, a viral infection is there, and they tell the rest of the immune system to get ready to fight off that viral infection. In people who have a more suppressed interferon response, some data suggests that this may contribute to the production of pro-inflammatory cytokines, which Brenna also introduced very nicely. And this uncontrolled cytokine storm, this inflammatory signaling, can lead to negative outcomes down the road, both acute and long-term. Now, we do know a little bit about the long-term consequences for people who had SARS coronavirus classic. And for some of those people, and also data from animal models, we know that severe cases of SARS coronavirus resulted in actual damage to the lungs, which was probably a byproduct of the cytokine storm that occurred. And some people have reported that, 15 years after the original SARS epidemic, they still had not completely recovered their lung function. But there's really a lot that we don't understand about how this impacts other organ systems in the body. And as Brenna pointed out, there are a lot of them that can be impacted by SARS coronavirus 2 infection or COVID. So I'm really looking forward to talking with this panel tonight about all of those different factors and what might contribute to some of these really unfortunate long COVID cases that Fran and Sarah have both experienced.
Great. Thanks. With next person I will introduce is Dr. Warren Dinges. He's a physician scientist, board certified in infectious disease and internal medicine in a private practice in downtown Seattle. And the name of his clinic is called the Seattle Infectious Disease Clinic. Warren is currently actively diagnosing, treating, and managing patients with COVID. So welcome, Warren. Can you tell us anything about the diverse COVID symptoms that you're seeing in your patients, and are you seeing any patients with long-term COVID symptoms?
Thank you, Don. Sure. I see COVID patients on a weekly basis. We have a lot more we screen for COVID that end up being negative, and many of the symptoms that patients present with are as reported in just common media sources. I mean, cough, shortness of breath, fatigue, malaise, fever, muscle aches and pains, joint aches and pains, and that's a pretty classic COVID presentation. Unfortunately, it overlaps with a lot of other presentations like flu and plenty of other viral upper respiratory illnesses like cold viruses, and coronavirus really is sort of in a family that were cold viruses. They can cause upper respiratory, so things in our head and north, and then lower respiratory, sort of things in our chest, in our lungs. And so when patients present, what we worry most about are things related to that, mostly breathing, and are they breathing well, but then later if it gets more severe, sepsis. But one of the things I use with my patients are the simple pulse oximeters, where we're measuring how much oxygen is in their blood. And that's a first marker for someone who needs to leave my level of care, which is in essence outpatient medicine, and go to the hospital. Most of my patients with COVID so far have done very well. They are managed in the outpatient setting. We diagnosed them. Some of my patients, we were in the asymptomatic category. They had a clear exposure, and we tested them and they're positive. And so that's, I'd say the majority of my patients are pretty mild disease. I don't see as much moderate and severe disease, people that end up with respiratory failure, multi-organ system failure, and then hospitalized and on a ventilator. So that's sort of my practice right now. We're involved in some research and trying to study and understand people and their immune responses, and then how those immune responses will change through time. So,
great. And thank you so much. A super, good summary. So next, I'll introduce Dr. Fran Broyles. She's the medical director of the Diabetes Endocrinology and Nutrition at Swedish Health System. Fran was infected with SARS-CoV-2 back in March. Hi, Fran. Thank you so much for coming and talking and telling your story. Can you take us through your COVID journey? Begin with kind of like how you were pre-COVID, talk a little bit about maybe how you think you might have been infected, the acute case or the early stages of the COVID infection, and then or COVID disease, and then how are you feeling now, and give us kind of an update on how things are going.
Thanks, John, and thanks for inviting me to be on the panel. So prior to COVID, I considered myself exceedingly healthy. I had no what we would consider preconditions that I would have thought would have gotten me into more trouble with COVID. I had had an episode of mild asthma with a really severe cold a couple of years prior to that, was given an inhaler that I never used, exercised routinely, good energy, long days in terms of practicing medicine, and never really had any big issues in terms of energy. So my husband and I got infected in early March. I think I was probably, I came down with symptoms around March the 4th. The lockdown in Seattle was, I think, March 6th. I do feel strongly that I was infected in the community. We were already being very careful at work in terms of, masks and screening patients. And so what's interesting is that King County published community cases by zip code, and did so for the first several months. And I think they're still doing so. And I live in a section of the city known as Capitol Hill, which had the highest community cases for the first several months in King County. So I do feel like I was infected in the community. Initially, what was interesting is I developed symptoms of body aches and sore throat, no fever, and some chills. At that time, Swedish was not keeping people from working unless they had a fever. So I was in the clinic for the first 3 days of my infection, not feeling great. And actually on day 4, which was a Saturday, I started to feel better. So I thought, this can't be COVID. I'm feeling better. And Saturday night, I had an episode of such severe nausea that I couldn't get off my bathroom floor. So for the non-medical, severe nausea can stimulate something called the vagal nerve and drop your blood pressure. And I literally could not sit up. So I would lean over to vomit in the toilet, and I would lay back down, drenched in sweat. And my husband brought me a pillow and a blanket, and I slept on the bathroom floor that night. All day Sunday, I was also nauseated. And then Monday, I began to develop shortness of breath, chest pressure, again, fever of about 99, and profound fatigue. And then for the next 2 weeks, basically rolled around in bed with my husband, who then also developed subsequent symptoms. My husband did have a very high fever, about 102.7, which lasted 8 days. We basically got out of bed to drink, to use the bathroom, and then went back to bed. I did develop a period of time of about 3 days of a really severe headache. As a doc, you sort of want to know, do you have a stiff neck? And are there other things that make you think you have meningitis? But this was a really, really bad headache, nothing like I'd had before. The next 2 weeks, so weeks 3 and 4, I attempted to go back to work. And I would last about 3 hours. And I was so exhausted that I had to go home. I couldn't walk down the hall in my office and have a conversation without being short of breath. And I couldn't have conversations on the telephone without getting short of breath. So the end of that 4 weeks, when I persisted in having shortness of breath, I called the pulmonary doc, who's a friend of mine, and said, you know what? I don't know what's going on here, but I'm 4 weeks out from my diagnosis and I still am incredibly short of breath. She said, come on over. So I went over, had a chest x-ray. It was negative. We did not do pulmonary function tests, but my lung exam sounded clear. I really didn't have audible wheezing. So he said, take an inhaler and use it, and let's see how that works. I did not have blood work at that time. The inhaler didn't help. I continued to have shortness of breath and chest pressure, that feeling of pressure. And I didn't really use the inhaler. And then I slowly sort of started to get better. I started walking home from work every day, which was a 45-minute vigorous walk up and down hills. It took me a while to get back up and moving. And then about 4 weeks after that, I had my first relapse. So developed, again, body aches, profound fatigue, sore throat, chilling, no fever, lasted about 72 hours. I got tested again for COVID because, of course, I'm working with patients, and I tested negative. So I thought, I have no idea what this is. I can't believe I'd gotten a cold or a flu because I was wearing a mask, washing my hands more than I'd ever in my life, social distance from people. It just didn't seem realistic. So blew it off. 4 weeks later, another relapse. Same symptomatology, again, lasted about 72 hours, got tested again for COVID, negative again. And at that point I thought, okay, you know what, either I need a psychiatrist or something is going on with my body. And I think as a provider, we, especially in the field of medicine, you really want a definitive diagnosis. You want to have either a lab test that tells you something's going on, or a chest x-ray. And so if you've got symptoms that nobody can explain, you start to question whether you're losing your mind. Since that time frame, I've had 5 relapses total. The one that I had most recently was 2 weeks ago and was probably the worst, which was discouraging to me. This one lasted 5 days. And 2 days, I literally could not get out of bed. Yeah, that's sort of where I am right now. I am in the post-COVID clinic at Swedish. I am scheduled for a chest X-ray and an EKG tomorrow, and some further lab work that I'm getting done. They have stopped testing me for COVID at Swedish after 2 relapses with 2 negatives.
So,
That's
Fran, just
where I am.
quick question. So a relapse, can you just define the relapse? So clearly it's fatigue, but can you define the other symptoms?
Yeah, so I call it a relapse because I do feel probably about 85% back to baseline in between time. And so I don't feel like maybe I have that chronic long-term symptom, but what happens is that typically I get body aches first, followed by really bad fatigue, chilling, and then the shortness of breath does get worse during that time. And I do feel the chest pressure feels worse during that time as well. I have had a few episodes where I've gotten headaches. And I would also say that I do feel cognitively like I'm just not back. And I think that's another piece for me of, is it just COVID? Is it just the insanity of the planet that's making me feel cognitively slower? But it's definitely not back to what I would consider normal.
And would you call that brain fog?
I would.
Great. Well, so we're going to ask you a lot more questions, obviously. Thank you so much for sharing your story with us. I'm sure lots of people are going to benefit. But for right now, we got one more person that's going to tell her story. Sarah Sewalelot is a co-owner of the Refinery Salon in Edmonds, Washington. Sarah was infected again, same as Fran, I believe, in March. So welcome, Sarah. So it's the same question I asked to Fran. Can you tell us what you were like pre-COVID, how you think you were infected? Tell us about the acute phase, kind of like the different symptoms and things that you felt, and then what's happening now as far as long-term issues.
Definitely. Thank you for having me, Dawn. It's so great to be here with all of you guys. And if only I had you in my pocket during this whole journey, I feel like just listening to Fran talk has been like, yeah, that makes sense. Oh, okay. Just comparing things. So, yeah, I was actually in Thailand visiting my family over the holidays, and I flew back January 12th and had a 9-hour layover in Beijing. So it was a big joke that I was like, patient 0 when I came here. But so I got here January 12th, came back home, and then February 12th, I was having just like respiratory issues. I actually ended up going to just my primary care, and they just said it was acute bronchitis. And at that time, there wasn't even really testing for COVID, like February 12th, it was a conversation being had, but it wasn't, they did like quarantine me in my own little room. And like, I had a mask on, and they asked me all the questions, but they didn't test me. And so continue functioning, at work. I do definitely think I was infected by one of my employees, and only because knowing what I know now, she had just said, hey, like, I need to go home. I have a fever. And I'm like, yeah, get out of here. Don't be, I have 21 employees, and we have a very high volume, area. So anytime anyone feels any kind of symptoms, I don't care what they are, they can't be around, at the salon. So she went home, came back that following Monday, and was telling me how it's so weird. I can't taste or smell anything. Mind you, this is still like the beginning of March. So I'm like, that is weird. Maybe you have a sinus infection. Again, not a doctor. So I'm like, who knows? Go to the doctors. Right after the shutdown, we closed our salon, I believe, March, I think the 15th, I believe, was when we're Snohomish County. So that's when we were told to be done. The following 2 days, my manager had called the night before because we were just shuffling everybody around, and she was like, hey, I don't feel good. I have a fever. And I was like, oh, great. I might go to the doctors. So she went to a drive-in clinic. At that time, they were just doing like, all the walk-ins and stuff. So she tested negative, but then literally I didn't know if it was like sympathy pains or what. That night I woke up and I was like, oh, I don't feel good either. So I also went into my primary and just the drive-in clinic, and I tested positive, and that was like March 20th. So for me, I think I couldn't tell at first if it was psychological, if it was actual like physical, because I didn't feel horrible. Like I never had a fever. I think it was around 99 degrees. I never hit that like high spike. She was like 103. She should have gone to the doctors, but she was just being stubborn. But it was the massive fatigue and migraine for like 2 weeks straight. So I live alone. So it's funny, like, you know, I watched TV, would have never originally, but it got worse as time went by. So Fran, I hear you with the whole can't move. I've never felt like that in my life. For me, the only thing I could really compare it to is like almost pneumonia. Like I had enough energy to get up, get tea or water, and I'd sleep for 9 hours. But it wasn't like I didn't have the cough. I didn't have that fever that everyone was talking about. And that wet, you know, some people were saying wet cough, some people were saying dry. It wasn't that. It was just chronic fatigue, foggy brain, and then like a nonstop headache. And then I lost my sense of smell and taste. So, you know, normally when you're sick, you want to eat all these comfort foods. That did not apply to me. My business partner and best friend also got it. So there was 3 of us in the salon that had it, but we were shut down. So I quarantined for 21 days, and coming back into the salon at that point, you know, our shop was shut down, and we really wanted to go above and beyond to make sure we were hitting all CDC regulations. And, you know, I was talking to Dawn a lot during this, like, hey, is this true about touch surfaces? Because obviously we are a touch service. So we did everything we could to make it, you know, as safe as possible. And I remember one day, the 3 of us who all are post-COVID, one of my employee goes, I feel like I'm an 85-year-old man. Like my body is aching. At this point, we're like painting everything. We're like, you know, sweat equity, doing it all ourselves. And I was like, oh, I thought it was just me. I was like, I do too. You know, before this, I've always been healthy. I exercise regularly, but I'm a hairdresser, so I'm always sore. You know, like my shoulders, my back, but it was a different kind of sore. It was like down to your bones kind of sore, where like everything just didn't feel good. And I worked with Dawn's clinic and donated blood and stuff like that. And then my best friend, she was working with Fred Hutch. So she was doing the whole trial where she had antibodies there. She was donating plasma. And I never would have thought about it as a relapse, but it definitely was. Like I would have 3 weeks of good. And then like the anxiety and depression I was suffering was really intense for me. And then I just feel like this year I've had almost every illness possible. And I'm glad that Fran also questioned her mental stability, because that has happened to me as well. And then just this past month, I ended up in the ER. I've been to the doctors 4 times for vision stuff. I had like double vision, swelling of the tissue of my eyes. It was really weird. I woke up one morning and the whites of my eyes were more swollen than my irises. And I was like, I am officially like just falling apart. And I went to the ER, they called it conjunctivitis, then they said it wasn't, and then they said it was vision strain. I'm still trying to figure it out. But when I spoke to you guys last time and you were talking about neurological stuff and nerve things, that definitely made me think, what is really going on? I haven't had the luxury of like being able to go into the doctors as often, because honestly, I would rather have people who really need it more than I do. I know that, like, for instance, my girlfriend who tested negative, she was definitely positive. But I think for me, just being, you know, a civilian out here, not being able to talk to people like you guys all the time, there's so much what ifs and how and whys, you know, and just, I talk to people all day long, clients that are just, you know, there's all so much fear about how we're going to exist with this. You know, should we just hole up in our houses and never leave? And I know for me personally, like, it's been hard staying home. And I know you guys hear that all the time because you're dealing with it firsthand, but I'm really excited for us to have this conversation so we can just, you know, talk freely about all the what's and how's.
So I have a question. When you lost your sense of taste and smell, was that before it was a known kind of association with COVID? Did you think you were like losing your mind over that as well? Is that another psychological thing, or how did you process that?
Well, and like the thing is, I was making like this like bone broth, like really like hearty stew. So I was super excited. It was happening in phases. Like as I was cooking all day, I could taste in the morning, you know, I'm like making this broth. And then I was telling my mom, I'm so excited. And I'm eating it. And I'm like, wow, I really have lost my touch. Like I can't even taste this. I'm like, salt, salt, salt. And then I was telling my mom that, she's like, no, I was just listening to the news. They're saying that they think one of the symptoms is loss of taste and smell. So then I go and like pick up something to smell like a candle, and I'm like, oh my gosh, you know? So yeah, I was one of the first people who had that symptom. So I absolutely felt like, wow, because there is something to be said about losing your like sense of taste and smell. Like nothing was bringing me joy. And all of my friends were like dropping off care packages of like things I normally wouldn't eat. I'm like, thanks. Might as well take it back with you, you know? So yeah, that was probably the most psychologically weird thing. And then I've had people say, when did you get it back? I don't remember. And sometimes I feel like it's not fully back, like my sense of smell and taste. Obviously it's back, but I don't feel like, I mean, I was raised by a chef, so I'm all about flavors and stuff. So, and maybe Fran can pick up on that too, if she feels like she's 100% back with her senses.
I am not. So I think that was also something that my husband and I experienced before dawn. They actually said, hey, guess what? If you lose your sense of smell, you might have COVID. So yeah, I would concur. And I definitely don't feel like it's back.
Yeah.
So, so this is the part we're going to try to have a conversation like normal people, even though we're mostly scientists and doctors, except for Sarah. So you guys, I mean, you know, those stories were fantastic. I mean, just, I mean, I think I have so many questions, but I'm gonna go last. And when we start with Angela, do you have any questions for Sarah or Fran or anything you want to bring up?
Yeah, I do. And I don't know if this is going to be comforting to you, but this is something I've been thinking about a lot through some conversations that I've had with a former colleague of mine from Columbia, Craig Spencer. He's an ER physician who contracted Ebola while he was treating patients in Guinea. And he was the famous guy who came back to and ended up on the cover of the New York Post because he went bowling before he realized that he actually had Ebola. And he told me that as a consequence of having Ebola and having recovered, he still doesn't feel right neurologically. He described very much what you have described about brain fog. And it's also been known after the West African Ebola epidemic, which was really the largest Ebola epidemic that's occurred in history. There were, 28,000 people who were infected with Ebola, and they started to report symptoms that sound actually kind of like long COVID and somewhat like some of the things you're describing. So vision problems, the sort of relapsing neurological conditions, issues with sense, relapsing fatigue, and discomfort in that way, insomnia, feeling depression and anxiety, which it's not clear if that's caused just because they're Ebola survivors, and that can be very stigmatizing. But a lot of the things that you're describing have now been reported for people who've recovered from Ebola. And even going back to the 1918 influenza pandemic, some people came down with something that at the time was called, I think, lethargic encephalitis, which was essentially similar again to what you're describing. So this doesn't seem like it's something that might not necessarily be unique to COVID. But I think that because so many people have been affected by COVID now in the US, I think we've had 11 million plus cases. We're starting to get an appreciation that a seeming respiratory virus or a primarily respiratory virus can cause all of these other symptoms. What we don't really know is what the mechanism for that is. But one thing that Ebola, high pathogenicity influenza, COVID-19 all have in common are these cytokine storms that Brenna introduced us to. So it's possible that this inflammatory condition, even after the virus is cleared, essentially reprograms entire organ systems, really, and the way that they're functioning. And that's one hypothesis for why people like you are continuing to test negative. You don't have a recrudescent or recurrent infection. You're not getting reinfected, and you're not persistently infected, but you have these symptoms that keep recurring. So that's something that I'm thinking about a lot, again, because it's also part of my field of study, and I also work on Ebola. But I think that we really need to start having an appreciation for the mechanisms by which acute infections, or things we think of as acute diseases, actually can persist for long periods of time. And in this case, cause really debilitating symptoms for people like you. And I'm really grateful that you shared your stories with us.
Angela, can I ask you a question, just because I don't speak your guys' language? You reference Ebola a lot, and I know that you guys just kind of piggybacked on the comparisons, but what are the comparisons as far as like to COVID-19? I know you said inflammatory, but that's kind of new to me.
Yeah, that's a great question. So there are some similarities, and there are some big differences as well. So Ebola is a completely different type of virus. It's in a completely different virus family. It's evolutionarily not related to coronaviruses. and it infects different types of cells and different organs. So Ebola typically infects organs in your immune system, cells called macrophages and dendritic cells, and it infects, which COVID or SARS coronavirus 2 does not. And it infects the liver, which SARS coronavirus 2 might, but that's not completely clear. So it has those things that are different, but the way that it causes disease, it actually does have some similarities, even though the disease itself presents differently. So Ebola causes a systemic cytokine storm that results in downstream loss of blood coagulation function. And so that's where you get the hemorrhagic disease that everybody knows about from like the hot zone and outbreak. Now, while people aren't developing a hemorrhagic fever because of COVID, there are these reports of vasculitis and blood clotting problems. And a number of physicians are observed early on that a predictor of severe COVID was a high D-dimer measurement, which is a measurement of a byproduct of blood clotting, basically. So people were having this abnormal, excessive blood clotting that might be caused by an inflammatory cytokine storm, essentially out of control inflammation. And just because it's presenting differently than Ebola does, doesn't mean that the same underlying mechanism is causing that dysfunction.
And I would like to ask something of Angela and potentially of Warren, and that is, as a provider, it seems sort of counterintuitive that if you had what would be a moderate case, or maybe mild to moderate case, i.e., I never had a fever above 100, and I certainly didn't have to go to the hospital, then why is it that I would get chronic relapsing symptoms? So, is there just no relationship, in terms of degree of cytokine storm or downstream effect? You would think that those people who did not have to be hospitalized would be much less likely to get into some sort of relapsing scenario, as opposed to those individuals who are very ill. So curious about comments on that.
So this is also a great question. Oh, would you like to go, Warren? I'm happy to let you jump in.
Sure. I just wanted to say, it's enormously varied in how a single person can respond and present with a disease that's the same virus or the same bacteria. So we see patients with tuberculosis, which we all think of as pulmonary tuberculosis, but it can also present as a very simple, small skin nodule. And then the sequelae or problems after it are enormously varied also. And by no means is someone who has rip-roaring, horrible disease then going to have the worst symptoms down the road. And sometimes it can be counterintuitive. And it also made me think of like Epstein-Barr virus or a common herpes virus. Epstein-Barr causes mono that we all know about, but herpes viruses cause, cold sores on the lip. And I've seen a patient die from that virus, new, young, healthy person who just died. And what's the explanation for why someone would die from something versus most people don't even know they have herpes and they never have a cold sore, never have any symptoms. And we can measure those antibodies in their blood and say, yeah, we know it's in there, but we can never really detect it. So I think it's enormously varied, and especially when we don't understand this chronic fatigue syndrome or myalgic encephalomyelitis is another term that's used. And it's these after the acute illness, the just inadequate or just difficult functioning level that happens after an illness. And it's a tough thing to measure, but we haven't correlated it well at all to how bad the initial disease was.
Yeah, and I think that's basically what I was about to say. I was going to add on to it as well that in some of the animal work that has been done on host responses to SARS coronavirus 2, they've looked at this in the ferret model, and this is where ferrets are experimentally infected. Ferrets have respiratory tracts that are somewhat physiologically similar to ours. So they're often used for influenza and coronavirus research. But ferrets don't actually get COVID-19. They have extremely mild disease. They lose a little bit of weight at most. and then they completely recover, even though they get infected. In that ferret model, they found that there was still profound suppression of those interferons, the antiviral early warning and attack system in their lungs, which were infected. So it may be that early on, even if you don't have severe disease, you're still reprogramming effectively the immune system from the get-go, and that could contribute to downstream responses even after the infection has been cleared. So I would say that, you know, disease severity is not necessarily an indicator for the long-term consequences of having an acute COVID infection.
Yeah, in fact, that is something that's been mentioned in some of these long-term COVID articles. That the people that it's a range of people that have a range of acute disease outcomes, and just randomly some people 10 to 33% are going to have the long-term effects.
Don, I was going to say, I think we have to be careful also. I mean, we may very well find out that the cytokines are completely normal well after this. And things like chronic fatigue syndrome and many disease states, and like depression or anxiety, there's nothing measurable in the blood that's any different in people. And that doesn't mean that it's not a debilitating disease that has treatments. So just because we can't measure it or see it on a chest x-ray like Fran's going to get tomorrow doesn't mean that it's not a disease process that needs to be managed and that has a diagnosable condition that we can manage. So one question I would like to, for both Sarah and Fran, is what do you want from your doctors? I mean, how would you like them to communicate with you about this, and what sort of questions are you not getting from them that you would like to hear?
Well, Fran, I'm sure our answers are going to be very different. I think for me, it's frustrating because they're not connecting any dots. Like, it's just every time, like I said, I've gone to the doctors more this year than I ever have in my life. And so that's partially why I feel like I'm falling apart and dying. Yes, I'm being dramatic. And also because when I start researching, or I'll call Dawn, I'm like, is this related? And then a lot of it is they don't know. So I would prefer, as someone who's not related into the medical world, to be a part of the process. Like, it can break it down for me, explain to, like, I've learned more just talking with you guys in the past 2 hours, you know, than I have in the 9 months or 8 months that I've had this virus, you know? And I think that, like, when Dawn sent out like the charts of stuff, or just even the slides that, you know, Brenna's shared, like the liver, the chest, all that stuff, I don't understand that. And I know there's so much stuff on the news, but honestly, you guys, I don't really pay attention to the news because I feel like, as far as anxiety, there's so much false information out there. Sometimes I'll spiral. So for me as a patient, I would like to just be a part of the process and have them, not that they're not taking it seriously, because I definitely don't want to say that, but I do feel like sometimes it's just like, oh yeah, you have pink eye. And I absolutely know that's not the case. You know what I mean? So, and I mean, I had to start like doing research on my own because it wasn't a contagious thing. It started, you know, it just came out of nowhere. And then my anxiety was off the charts that week. Like I called in sick twice. I never call in at my work, but I just couldn't be around anybody. You know, like I was having like little borderline minor panic attacks, which is completely out of my wheelhouse. So I think for me, involvement on what this looks like, and like, even if they said, hey, you know what, we don't have the answers, but we will keep you posted. Like, we're going to have you be a part of this just so I can have a peace of mind.
So Sarah, just to clarify, you're saying kind of be honest and transparent, but even if they don't have answers, you'd be okay with, I don't know.
I mean, I appreciate honesty. And I think for me, I have more of a respect level if someone says, hey, even as a professional, it's what you guys do. This is such a new thing that I don't expect someone to be 100%, but to say, hey, I'm hearing you, and I understand that you're thinking this might be related. I don't have an answer for you, but I want to dig deeper into it. I've never had like the thorough testing that Fran's had. Like, no one's ever done any none of that. And I think part of it is I've gone to the doctors in the past 8 months for 3 separate issues. So, you know, and a lot of them are just ongoing. Like the fatigue, I mean, I have no words to explain how like heavy the chronic fatigue is. Like, it's definitely, it's crippling my life to the point where I'm 40. You know what I mean? By 3 o'clock, I'm like, good night. And it's not even a question. Like, I literally can't fight it. I'm on the couch and I will sleep for like 4 hours, which is not like me. So it's just more frustration, you know?
Yeah, and I would certainly say, Sarah, despite the fact that I'm a physician, I share, some of those same feelings that you have. I think the issues are that however, am more aware that they really don't know.
Yeah.
I'm still pretty surprised that if I'm talking to a colleague and they find out that I've had COVID and they want to know how I'm doing, well, gosh, how's it? And I tell them that I've been having these relapsing symptoms, they're completely like, what? Are you kidding? Gosh, I didn't know that happened. So I think there's still a huge lack of knowledge out there about this sort of either chronic sustained or chronic relapsing symptomatology. And I think, validation is always a huge issue. And that is something in medicine that we really can provide patients. Like, we know that you don't feel well. We know there's something going on with you. We don't know exactly why. And I think that's really what we need to be trying to push out to patients. I think for me, I have probably tried to suppress and deny the issue of this is not chronic fatigue syndrome. This is not MECFS. I don't want to go there because I take care of patients who are in that category. So I'm just assuming this is going to get better at some point, or they're going to come up with some treatment that is going to improve things. Because if I didn't think that, I would be having a much tougher time right now, I think.
Let's talk about potential treatments, and I'll just kick this to Brenna and Angela and Warren. And so we've talked about cytokine storms to the general public. They may not know exactly what that is, but just imagine, it's a combination of different proteins in your body all being released at once or one after the other, just contributing to these different symptoms that you're hearing Sarah and Fran describe. So is maybe just some comments, just something that might make Sarah and Fran feel a little more positive. Any ideas of different treatments that might come in the future that might help these people with the long-term COVID?
So one thing that has failed to treat patients with severe COVID are more targeted therapies that target individual cytokines that make up the cytokine storm. And those treatments were already developed for other chronic conditions that are caused by this chronic inflammation or chronic activity of these inflammatory cytokines that's not supposed to be there. And just because they failed to treat patients with really severe COVID, so IL-6 inhibitor, IL-6 is one of these cytokines. It's a very potent pro-inflammatory cytokine, and there's a drug called tocilizumab that can treat IL-6, chronic IL-6 activation. That was tested in a clinical trial for patients with severe COVID, and it didn't appear to work. But drugs like that selectively turn on or turn off or modulate the activity of some of these cytokines, if we can figure out which ones are driving this, that's one potential treatment. If we can find out maybe it's not a cytokine, maybe cytokines kick off the process, but it's something else that is mediating these long-term symptoms, that's something that we could potentially target and treat as well with things like monoclonal antibodies, antibodies that are targeting one specific protein, essentially. So if you think of a cytokine storm as like a cacophony, like if all of us were to talk at once, it wouldn't make any sense and people would probably want to plug their ears. That's kind of like a cytokine storm. This is like if one of us was super problematic and we just muted them. That's one way we could consider approaching treatment for long COVID. But the key there is that we actually have to find out which protein it is or family of proteins it is that's causing these symptoms. And it may be different for different people. For example, if you have neurologic disease, you might have to target this pathway. If you have myocarditis or chronic heart disease as a result, you might have to target something else. So I think that kind of taking those approaches will be really helpful, but that does depend on us understanding how this is even caused, like what is the underlying mechanism, because just saying, oh, it's probably the result of a cytokine storm, that's not very specific, and it's really difficult to develop a treatment for that. And that's actually what we also see with severe COVID patients. The only treatment for those patients that seems to work and have a mortality benefit is dexamethasone, which is a corticosteroid that's a pretty profound across the board immunosuppressant. So that's kind of like taking a big club to the problem when maybe you just want a little hammer to target something specifically, but we have to know what that thing is. And I think the same might be true for long COVID. So I'd be very curious to hear Brenna's thoughts on this though.
Oh, well, I mean, I actually kind of agree with you. I mean, it's one of those things that, you know, hearing Fran and Sarah's stories, you know, they're having relapses and the biggest thing is fatigue, but there's other symptoms as well. So is the underlying cause for Fran's different than the underlying cause for Sarah? So do you guys know if there are any studies where they're looking into this to find out, you know, especially for long haulers, you know, what, you know, if it is a cytokine thing or if they're looking into what is behind all of these relapses?
I don't know. I'd actually be very curious to hear what Fran has learned being a patient at the Swedish long COVID clinic, because I know that they are enrolling patients at a variety of places, including Mount Sinai has a large center now that's been established for enrolling large patients to look at this, but I don't know specifically how they're going about that. I don't know. I mean, I'm sure it's probably a combination of blood work and cytokines and maybe transcriptomics, or looking at all the genes that are expressed in the blood or in a tissue sample. But I don't really know what exactly has been planned in those studies. So I don't know, Fran, if you can shed some light on that.
Yeah, I would say that this is what I feel about the post-COVID clinic. I feel like they have no idea what they're doing and they're just trying to gather as much data as possible. So that's you know, that's unfair. I mean, it's not that they don't know what they're doing. It's just that they don't know what's going on. So they're just going to do a huge sort of panel and sort of look to see commonalities amongst different patients and whether or not they can, you know, delineate anything. I think one thing that was interesting is that, you know, there was some the genomic strain of the type of SARS has been identified. And I know that one of the patients who was readmitted with reinfection at Swedish had the genomic testing done twice and had two different versions of the virus. And I think that's another piece of this is one form of the virus more likely to cause long-term sequelae than another genomic form of the virus. So that is another piece of this. And, you know, I do have to say that I feel I'm trying to battle some anxiety around the fact that if indeed there's a window to treat those of us who are relapsing, I feel like we need to do it quickly. I mean, I worry because I see people with chronic fatigue who've had it for a decade and now nothing works. So I feel like, you know what, if there's something that we should be trying, we should be doing it sooner rather than later. And I don't know whether that's valid or not.
Fran, I have a question. Are they taking your blood like on a regular basis? Because you can imagine that what they might find in between relapses and just before a relapse and during a relapse are all going to be different. Are they doing that kind of blood mining?
They haven't, and I asked about that. Like, should I get blood done when I feel at my worst? I was going to do that, but I literally could not get out of bed. So I do think that would be valid to do the panel when you're feeling terrible, and to do your panel when you're feeling better, or at least, you know, sort of back to baseline.
Are you guys seeing in like where you're working with, I guess for you, Warren, because I know you're working a lot with post-COVID and all of you, are you finding that it is like enhancing issues that might have been prior? Like, you know, for instance, like me, I've had mild anxiety in my life. Are you guys seeing that it's like, I guess for you, Fran, because it's like you would be able to diagnose yourself more. You said you were healthy before. Are you guys seeing any patterns like that happening? Or a lot of these things just like out of the blue, things that people have never experienced, or like, are some of them, oh, okay, well, in their history of their health, they've had, you know, X, Y, Z? I guess that question's for all of you guys.
I just haven't seen enough patients with long haul symptoms to really have, you need to have 100 patients, and that's why these databases are so important, and pools of plasma and blood from patients during symptoms and without. And it may very well be we find something in a cytokine or some other aisle that's wrong. But I'd say more likely than not, if we parallel so many other situations where we have people with chronic debility after, whether that's cancer, chemotherapy, there may be nothing we find. And it might be something that we really is a broader that covers the spectrum. Right now, we have no treatments approved by the FDA for chronic fatigue syndrome or myalgic encephalomyelitis, if you want to call it that. We don't have anything. So we really treat the specific symptoms. We treat fatigue. There's a medicine that will make you more alert, and it's called modafinil and others in the class. We treat anxiety with anxiety medications. We treat shortness of breath with established therapies that pulmonologists know for dealing with that. That's really how we can treat patients on a daily basis, and that I see. And it's a little blunt, I guess, but you have to go with what is the symptom. And that's part of when I talk to a patient. What are you feeling today? How is today different than last week? And during one of these episodes, what is your worst symptom that's keeping you from doing the things that are important in your life? What's keeping you in bed? And those are how we manage the patients, at least now, and with any chronic fatigue syndrome or something post any infection, any disease. Ask them their symptoms and manage those symptoms.
Brenna, do you have a question?
I was just wondering, because I don't know of anything that's around here, but especially for somebody like Sarah who doesn't have, quick and easy access to, all sorts. Are there places that she can go? I know you mentioned something like that there's things that are being set up now where they're starting to look into long haul cases. Are there places that Sarah can go so she can get, I guess, more involved or to get more answers than just seeing her primary care physician or, a drop-in clinic?
That's a great question.
So I would say, Sarah, you absolutely could go to the post-COVID clinic at Swedish. Certainly that, information I'm happy to share with you. I think the hard part, Brenna, which you're bringing up, is that, the awareness that these clinics exist for the average primary care physician who's seeing a patient like Sarah, people don't know. And they really, I had a patient that I spoke with who, this was probably in April, before the post-COVID clinic in Swedish had been developed, and she was having a Zoom visit with one of the infectious disease experts at Northwestern, because that was the only place that she knew of that had a post-COVID clinic at that time. So I think a lot of people are finding these by, being on Facebook, groups, or going online and Googling it. But for something local, we really need to have some sort of local, information about where you could go.
Yeah, I will definitely look into that, because it would be nice to, and like when I was working with Dahl, got a hold of me in the beginning, because his lab just wanted to do blood work and stuff, but that was just like, it was like, hey, use me for science. I don't care. I mean, I know a lot of you guys were in the dark because it's so new. So I understand, like, I know Dawn was like, would you prefer them telling you don't know? I understand that's frustrating too, but for me personally, yes, I would. Because it's better than them just disregarding me, even though that's probably not what's happening. I can only imagine how the medical field feels right now, so overwhelmed with all of this. I just think for me personally, if I could connect the dots, even if you guys can, just like, just talk me through it.
Talk you through the what you're experiencing and just be a little more clear. Can you explain a little better?
Like what Warren said, like when he sees his patients, he asks like, how are you today versus how were you yesterday? Like, I guess, and I love my doctor, but like, again, she's primary care, right? So I think if you're not working as closely with COVID as you guys are, I think she's trying to think of like, oh, what could cause this, instead of me being like, well, you should know she's seen me for 15 years. Like I've never had this kind of medical history where I'm chronically in, seeing her every 2 months, whether it's like I've had like the most like Warren said cold sores. I've had like 3 cold sores this year. I'm like, what the heck is happening? Where she's giving me like, oral and like medicine for me to take. And I'm like, this is the weirdest thing. So that's why I was asking, like, if you guys are seeing that it's symptoms that maybe we've had dormant in our whole lives, or if it's all new, because for me, I'm having a lot of new things happening. And I guess if I was working with a clinic that was, more specializing in this, it'd probably be a better experience for me than every time I'm going in, I'm treating a new thing. And the question of how do you feel today versus yesterday or last week has never really happened for me.
Yeah, see that what you just mentioned is something that's important to listen to patients. A lot of people don't realize that cold sores also present when we treat HIV. And so in the first 3 to 6 months after we treat HIV, patients will have enormous numbers of outbreaks of cold sores. We don't even know why that occurs, but I've seen it now, so it's regular, and I actually initiate the conversation with patients about it. And when you're just saying that now about cold sores post-COVID, it makes me say, similar process. So
yeah, and for me, it
good
was
communication.
Cool. You're a business owner and COVID shutdown is probably just stress and anxiety. I'm like, oh, okay, yeah, that makes sense. You know what I mean? Because I'm thinking my immune system's already down, and I pretty much topped up to blaming everything on COVID. But still, it would be nice to be able to, like, with Warren saying, well, that is a sign, or that could be connected, or who knows,
Well, and that's how these databases of patients and groups are so important, is they then would ask all of these questions and happen to come to one of, oh, well, I didn't think that was important, because what a single provider will see is limited, just like what you see is limited. And so it takes pooling all of that from a bunch of patients and a bunch of providers to make those associations we would never see. And also pooling samples for lab analysis. You need to have thousands of patient samples where this cytokine may be up in these people, but not in others. And so how do you do that? And the way we do research is to get large numbers of information and collect that data, large amounts of information and data, and then try to analyze it afterwards.
Mm-hmm.
I also want to say, I think they're starting to, so initially it was about trying to keep people alive. And the idea that people were having these symptoms after they were being infected, well, it wasn't a high priority, because they would just, they needed treatments that were going to keep people from the worst outcomes, right? And now I think we're kind of be able to step past that and begin to really analyze people that are having these issues, these long-term issues. And it's going to be super important to figure this out as best we can, have treatments for you that are going to be effective and make you feel better and increase your quality of life, right? So you can not be tired all the time. And I think that that's something we really, I'm hoping will happen, and I hope it happens soon. That would be great. This part of the, at this time, we're going to move to the kind of the summary phase. And what I'm going to do is give everybody an opportunity to kind of just give their thoughts, their final thoughts on the episode, and anything that you want to add that wasn't able to be said. And we'll start with Brenna, and just please summarize your thoughts, Brenna.
Okay, well, first of all, I want to really thank Fran and Sarah for joining us and sharing your story. Not only this to kind of give each other support to say, I'm not crazy. You're experiencing a lot of the same symptoms, but you also have some unique symptoms as well. So it kind of gives us an idea of the fact that as much as patterns are emerging, there's also a lot of stuff we don't know. And that also brings up what we were just talking about, trying to find ways to get databases to primary care physicians or patients to places where they can actually contribute and help, with the pool of knowledge, so that we can figure out what these patterns are, figure out the best treatments, and take care of anybody who's not only acute but long-term COVIDs as well. So thank you very much.
That's great. And Angela.
So I'd like to really echo Brenna's thanks as well. It's been really, really helpful for me as somebody who's always talking to the press, I feel like, about this and other COVID-related issues, to actually hear what it's like to be a patient with long COVID, and also to hear from Warren, since I'm not a physician and I spend most of my time doing research on animals. And actually, I really spend most of my time doing my research on the computer. So it really is incredibly helpful to have a human face, to hear in your own words what you're going through. And I would just like to end really with a message of hope. When this started, when both of you were infected originally, we really didn't know anything about this virus. And there's still a ton that we don't know. But as you pointed out, they're at least starting to collect the data from patients like you, even if they don't quite know exactly what to do with it. And as we were just discussing, having that data is going to be really key to getting to the bottom of this. It's going to be on my side of things. We've also developed a lot of different animal models, including one that I am working with or about to start working with to hopefully try to model some of the actual clinical features of long COVID. And that won't address any of the anxiety and the things that you yourself have experienced, but maybe using systems like that in combination with these patient databases that we're collecting, that might be helpful. And we also do have very good news for a vaccine going forward. So hopefully we'll prevent other people who haven't yet been infected from going through what you've gone through. But I think that we'll probably be studying patients like you for years and maybe even decades to come, because it's quite clear that even after this pandemic is over, there is still going to be a lot of people that need science to help them out and to develop great therapeutics that can really improve your quality of life. So thank you so much for sharing your stories and your perspective. And it's been really informative and useful to me. And it's really, I think, a great service to everybody for you to share your stories with us. So thank you again.
And Warren.
Thank you, Don. First of all, I also want to say thank you to both Fran and Sarah. I really do appreciate your perspectives, and I would really, I think it's important you and other people like you share your issues with your providers and tell them, let them know. And if you don't like what you're hearing or they're not asking the right questions, let them know what they should ask. And why don't you ask me about how I felt this week as opposed to last week? So certainly. And then also I'd like to echo with Angela. I think there is an enormous amount of hope. You have to understand that we now have 3 vaccines that are very nearly entering the market. 2 of these vaccines, the lead, the Moderna and the Pfizer vaccine, are based on a technology we've never used in any vaccine before in human history. These RNA vaccines. That's shocking to take a new technology off the shelf, roll it out in a very short time window. And we're using that in patients right now, and at least in clinical trials, and very soon, hopefully rolling it out for treatment. That's amazing time window. And that didn't happen with Ebola. It took decades for that before we got a vaccine or monoclonal antibodies. That didn't and still hasn't happened with SARS-1 or with MERS, which is a similar virus, also spread similar ways. So this is remarkable. And part of it, though, is that there are so many people affected. And we have to realize that. And it's very different. More people have been infected since basically the start of this epidemic than have. So more people have had COVID now than have had HIV in the entire history of the HIV epidemic. Different diseases completely. One's chronic, one's shorter term. But it's important to realize the scale with which this has burned through our community and the entire world, and no one is untouched by this. And we'll be learning about this for decades and talking about this probably for centuries. So it's also very amazing at the steps we've taken to get a vaccine rolled out soon. I'm looking forward to having it in my office and to the first shot I give to patients. I remember I was the second person in the country to get a COVID, not a COVID, SARS, what is it? The swine, not the swine flu, the influenza H1N1 vaccine. I was actually the second person. I volunteered myself for that research. So again, another time we stepped up as researchers and provided something. So I am hopeful. I'm looking forward to the vaccines. I think those will beat therapeutics out that will alter the disease process.
And Fran?
Yeah, I think one thing that I would like to see happening, sort of not necessarily politically, but in the information that's being pushed out to the population about COVID, is it's not just about whether you die or you don't die. It's that a third of you may be living with us for a very long time, And I think that's another reason that people need to understand why they really need to do everything in their power to avoid getting this virus, at least until we have a vaccine that is going to be effective. And, there's rarely a vaccine that's ever 100% effective. So I think getting the information out is huge. And then I do think the second issue is that I feel like those of us who have relapsing symptoms, there's, these Facebooks, there's articles, but the reality is that there really need to be robust clinics that enroll us, if nothing else, to monitor and try to figure out what's going on and to make that understood and available for as many people as possible.
Great. Agreed. Sarah.
I will say, I thank all of you guys. I have a lot more clarity for one, just talking to you guys. I have a lot of my friends, families, and clients that are waiting to watch this video because there are so many questions from us, normal civilians over here that don't understand all the breakdowns. And I think that, I do have a handful of my friends who did have the virus and are living, like Fran said, with a lot of these long haul issues, that it's not just about, oh, you should be happy that you had it and you lived, or you didn't. It's not, there is a big gray area. And also, I appreciate the clarity of you guys saying that there's so much that you still don't know. Because I think as someone who doesn't understand medical stuff, I just get frustrated and angry because I do want solutions, which is, I think, why I was trying to explain that it would be better to know that maybe the answers aren't there. Because like I said, there's a lot of false information out there. Yeah, the knowledge that I've had today is more impactful than I think the whole year that I've had experience in this. And I feel very lucky to be on this panel. So thank you, Dawn, for inviting me.
We're very lucky that you're here. So I'll just wind everything up. So just to remind any of the viewers that we are now in what will likely be the worst 2 months of the epidemic. The outcome of how many people will live or die depends on all of us and our abilities to socially distance, especially over the holidays, washing our hands, doing the number one thing that we know works, which is to use face masks. Fran and Sarah have told you that long-term COVID is nothing to take lightly, and they've in many different ways throughout this episode. So please take the precautions so you can get to the end of this pandemic in good health. If you like this content, please subscribe and like the video, and add any comments below, and importantly, add any questions that you have so we can address them in a Q&A on this topic that will be our next episode. Also, let us know any other topics we should cover. Have a good week and stay healthy.